Hello, my name is Dr. Neeraj Patel. I'm one of the pulmonologists at AdventHealth Tampa, and today we're going to talk about lung cancer screening. So there are several things we are going to talk about, and this is a relatively new subject in terms of cancer screening. We have been screening lots of cancers like colon cancers and prostate cancer, breast cancer for a long time. But there's lots of things that have changed in the last 10 years as far as the lung cancer screening is concerned. So today we're going to talk about those guidelines and why it is important and what has changed in the last few years as far as cancer screening is concerned. This is the disease of really last 50 years. In 1900s, as you can imagine, there was only 80 people who were diagnosed with lung cancer. In 1912, Adler wrote an article, and then he apologized that this is such a rare disease that he should not have wasted his time talking about lung cancer. You know, it is given that 1900 there was limited imaging available, and smoking was not that prevalent, but there was other occupational exposures like fires and exposure to colds. But still, like in the last 50 years, with the advent of smoking and other methods of exposing lungs to different pollutions, the lung cancer has really taken off. So this is a very interesting statement. Except for smoking cessation, there's no public strategy for this disease. And even though we know that incidence of new cases are increasing, more than 200,000 patients get diagnosed with lung cancer per year, and there are more than 100 million current and ex-smokers in the United States. This is unchanged. Like, mortality from lung cancer has not changed significantly, and we'll talk about those statistics as well. 6% of cancer death, or 6% of all-cause mortality, is caused by lung cancer. And in fact, even though this is such a high and such a big public burden, there's no real strategic initiative as far as research and funding is concerned for this epidemic. So it's staggering. So many people died, and it is such a deadly disease. Still, nothing concrete or in the right direction as a public policy we have come up to. This is a history of lung cancer screening. So lung cancers in 1950s and 60s started becoming more prevalent, and we had realized that it has associated with smoking, and incidence of smoking kept on going up and up until the last few years. So there has been effort to diagnose this disease earlier. So in London, 1960s, there's a trial done to diagnose lung cancer on basis of X-rays, and it showed no change in mortality. In 1970s, there's X-rays and low-dose CAT scan studies done. So there's LCAP trial, which was early lung cancer assessment program, where low-dose CAT scan was better than detecting cancer, but didn't show significant improvement in mortalities. In 1990s, Mayo Clinic had a study done for comparing low-dose CAT scan, which found the baseline cancer rate of 2%. After 5 years, 74% had lung nodules and 95% were benign. But this study was not large enough to determine mortality benefit. So in 2000-2004, we have a national lung screening trial which showed significant reduction in mortality if patients were screened, or right patients were screened with low-dose CAT scan. In last 10 years, lots of things has been changed. So we will be hearing that in future about molecular markers and proteomic analysis as far as lung cancer screening is concerned. So currently, we know that this disease is pretty deadly. 18% survival rate at 5 years, and this has not significantly changed in last 45 years. So that's very impressive that with advent of modern medicine and diagnostic and therapeutic tools, this disease has really not changed a lot as far as outcomes are concerned. And most of the thing is attributed to late diagnosis of this disease, as we'll see. So this is roughly comparing lung cancer to other cancers. 18% survival rate in 5 years. Compared to that, prostate cancer has 99% survival rate, and breast cancer has 88%, and colon cancer is 64%. So this is universally very deadly disease. One of the most important thing about lung cancer screening is always recognize late, and there are significant opportunities to detect it early. And if you detect it early, it really changes the game as far as survivability is concerned, and diagnostic and therapeutic options are offered. So, 18% survival rate in 5 years is because of late diagnosis of disease. So if this disease can be diagnosed a little early, definitely improves the survival. And I think that's where the focus needs to be placed as far as lung cancer is concerned. So as we stated earlier, almost 160,000 deaths. Lung cancer is responsible for 28% of all deaths. So think about that. Cancer is among top 3 causes of death in the United States, and 28% of all deaths are from lung cancer. 5-year survival rate, again, 18 to 17%. Nothing has changed in the last 40 years. This is another important statistics, that number of person year loss from lung cancer is 3 times that of breast cancer. So in the short, once they're diagnosed with lung cancer, they are 3 times more likely to lose the time or rest of their life than colorectal cancer. So let's say breast cancer patient is going to survive 3 years or 30 years. Lung cancer person is going to survive 1 year or 10 years, respectively. And we'll talk about the cost of this delayed diagnosis and also productivity loss, which is again staggering. This is how this cancer is being diagnosed and treated. So lung cancer, again, as we know, that it's stage 1 to 4. Stage 4 is metastatic disease. Stage 1 is somewhat localized disease, and then stage 2 is localized but large, and stage 3 is a localized disease with some local spread to regional lymph nodes. And stage 1 disease is usually treated with surgery. There's evolving evidence that radiation might be as effective, and there's, of course, chemotherapy for larger lesions. As you can see that when it goes from stage 1 to stage 4, the surgery is very limited option and virtually not an option in stage 4. In some stage 3, especially stage 3A, surgery could be an option, but mainly cornerstone of treatment is radiation and chemotherapy. And at the end of the life, it's just a palliative care. So 5-year survival rate, as it shows that in localized cancer is 57%, and patient with a distant metastasis is less than 5%. So what it means that if this disease can be diagnosed early, let's say compared to stage 4, if this disease can be diagnosed in stage 1, survival rate can jump significantly. There's for early stage 1 cancer, this survival will be somewhat up to 92%. So this is, as we were talking about, the cost of taking care of patients with lung cancer. So if you divide cancer in stage 1, 2, 3A, 3B, and stage 4, and this is a per month cost of taking care of this patient after being diagnosed with lung cancer. So every month, stage 1 cancer, after being diagnosed with lung cancer, the treatment will cost $7,239 a month. Compared to that, stage 4 cost is $21,441. So this is a 3 times increase per month in treating this patient for lung cancer. So if this patient could be diagnosed earlier, there was significant cost benefit in early diagnosis. It's major difference. And as we know, that stage 4 cancer is not curable. So this cost, like $20,000 per month cost of taking care of a patient with lung cancer, stage 4 remains like that for the rest of their life, versus stage 1 cancer, as we know that more than 90% of patients do get survival and get cured. So this is number one case related this is very staggering, as you can see, from prostate to breast to pancreas and colon cancer. And this is significant increase in number of the deaths from lung cancer compared to other cancers. So this is again reinforcing all those things. This is number one cause of cancer death in the US, and it is responsible for 26% of estimated cancer deaths. And this can be again seen in these slides. It's probably combined breast and colon and maybe prostate together. That's how the lung cancer kills that many people. Lung cancer kills more than 155,000 patients. This was 2017 data, and estimated more than 225,000 new cases. In 2017, more than 13% of patients were diagnosed with cancer without lung cancer. So even though it is responsible for less than 15% of newly diagnosed cancer, it is responsible for more than 26% of total death. So there's big discrepancy between incidence and mortality of this cancer. So this cancer is very common. It's not a rare cancer, and there's more than 200,000 patients every year. And as this incidence is, even though there's a significant decline in smoking, incidence of cancer from the lung is continues to go up. So lung cancer kills more than 3 leading cancer combined. So as we talk about breast cancer, prostate cancer, and colorectal cancer, even though there's so much public awareness about those cancers like prostate, colon, or breast, lung cancer kills more people. And we're not sure whether this is just a population bias where lung cancer has not been given that much importance as well as screening is concerned, or somehow it has been viewed as a self-inflicted behavior, or maybe that so far there has not been very effective treatment for lung cancer as far as advanced cancer is concerned. But there are new diagnostic tools we have, and new imaging methods. I think this disease can be diagnosed earlier. And earlier disease definitely can lead to better outcomes. And we do have therapeutic interventions to treat this cancer early, which can definitely affect long-term outcome, survival, and cost of caring these patients. So this is a global data. Again, 1 in 5 cancer deaths are caused by lung cancer, and more than 1.8 million people will be diagnosed with lung cancer. So this is not only a disease of the United States, it's global problems. And it is number 1 cause of cancer-related death worldwide. So 1.6 million people will die from this cancer, and 17% 5-year survival rate. So survival rate has not changed compared to whether this is concerning United States or global issues. Every 20 seconds, 1 person dies of lung cancer. So, there could be a difference in cancer demographics across nations. In developing world, you might have higher likelihood of liver cancer or cervical cancer. But as far as mortality is concerned, lung cancer is still number 1 cause of death. And as you can imagine, there are more than 300 million smokers right now in China. And this is just beginning of epidemic where we will continue to see mortality and number of patients who are going to die from lung cancer continues to go up. So this is a study, lung cancer screening trial which was published in New England Journal of Medicine. And this is a trial which sets the foundation for screening guidelines for lung cancer. This study used low-dose CAT scan to screen the patients, and it compared to a routine chest radiograph. And this is a year since randomization and number of lung cancers. So definitely a low-dose CAT scan diagnosed far more lung cancer than chest radiograph. And you can see that the benefit was early on. So within 1 year of enrolling this patient in the studies, you can see major difference as far as how many patients were diagnosed with lung cancer. And that truly reflects in mortality in this slide B, that there's almost 20% reduction in number of cancer death from lung cancer in a subgroup where low-dose CAT scan was used to screen for lung nodules. So again, low-dose CAT scan significantly improves survival from lung cancer compared to other means like routine chest X-ray. So this creates foundation of new guidelines to screen the patient with low-dose CAT scan. So this is very interesting, and if you can see in the middle of this slide, one side there's a tumor diameter and then percentage of cases and volume doubling time. So there's a detectability threshold. So without cancer screening, most of the lung cancer will be diagnosed when it is almost 1 centimeter size. And at that point, so you will have 75% of patients will diagnose at that threshold. And unfortunately, you will see that significant increase in symptoms of metastasis. So what does it mean is that when lung cancer becomes more than 1 centimeter, it might lead to have some more symptoms and lead to diagnosis of lung cancer. But by the time it gets diagnosed, it is more than half of time has been metastasized. So this is very unfortunate. That's where we lose the battle. When disease gets diagnosed late, there's limited options to treat it. So unless we put more focus or attention on screening high-risk patients, this disease is going to be diagnosed late because early disease is not symptomatic. So a patient might have like a 1 centimeter lung nodules, and that might not lead to any symptoms at all. And by the time it becomes symptomatic, so it's too late. So most of these patients should be screened. So if you wait for the symptoms to happen or symptoms to develop, this disease is going to be not curable. So this is the benefit we get by screening this patient. If the patient gets diagnosed early enough, let's say stage 1 and maybe early stage 2, there's 88% chance that patient will survive. If more patients get diagnosed at stage 1, let's say if you have 40% to 40 to 50% patient gets diagnosed at stage 1, there's a $1.2 billion can be saved per month. So this is a huge public health cost can be saved. So screening, sometimes it looks overwhelming that why we have to screen so many patients. But if you look at this just numbers, that if you diagnose and if you screen the patients for lung cancer, high-risk patients, the $1.2 billion cost saved. And we are talking only about just diagnosing 46% of patients at early stage lung cancer. Other thing is that even after initial presentation, let's say patient gets screened and diagnosed with incidental lung nodule, further treatment and diagnosis, that lag time is almost 5 to 6 months. If we can do something to provide comprehensive care, let's say patient gets diagnosed with lung nodule, gets biopsied and gets treated. So if those things can be done within 1 month, more than $2 billion, $2.5 billion can be saved. So again, it's not trying to diagnose, it's also trying to diagnose and treat this patient within a reasonable period of time, not only saves the life, saves lots of money. So again, lung cancer lots of times looks as an orphan child, where we don't even pay that much attention, and once we pay attention, we just don't diligently follow up. So if patient has some incidental lung nodules, we'll wait for a few weeks to get biopsy done, then we'll wait for a few weeks to see a surgeon or radiation oncologist or oncologist, and then it will wait for a few weeks to get treated. So this time is usually 4 to 5 months. And if we can somehow shrink that, it can save lots of money. This is a brief slide. Again, we know that tobacco is a #1 cause of cancer death. Other environmental occupational exposures like asbestos and radon definitely has a known risk factor for lung cancer. Other household air pollutions and secondhand smoke and outdoor pollution also has been thought to be contributing cause of lung cancer. So with that, we can talk a little bit about incidental lung nodules. Incidental lung nodules are the nodules when a patient goes to elective surgery, or a patient goes to ER for unrelated diagnosis and have a scan done. Let's say a patient has a CAT scan of the abdomen done, and the radiologist will comment there's a lung nodule. So those are the incidental lung nodules. More than 1.5 million adults in the United States has incidental lung nodules, and after that only 29% of the lung nodules has been followed up. So 71% of nodules, nobody just do anything. So this is just it's not a total medical negligence, but we don't put enough attention to address this thing. So let's say a patient does have chest X-ray, or a patient had a pre-op X-ray for spinal surgeries, or patient had a cardiac CT or abdominal CAT scan, and radiologist has documented lung nodules, and unfortunately 71% of time nobody follows it. And the statistics is very impressive, and even in a very reputable journal like New England Journal of Medicine, radiology journals, it has been shown that 25% malignancy rate for actionable incidental nodules. So this is the patient. These are the patient who comes to the healthcare systems for unrelated reasons and diagnosed with incidental lung nodules. 25% of those nodules, which are actionable, means like nodule size more than 8 millimeters in size, and those incidental findings will turn out to be cancer. So this is a huge opportunity for most of the healthcare system, where we can do population-based screening of all the radiological examinations, and this nodules needs to be screened, needs to be caught, and needs to be followed up, because 1/4 of those nodules, which are more than 6 to 8 millimeter size, will turn into cancer. Compared to that, if you screen general population, you will find 2% of positive rate for a cancer diagnosis. So these are the ICD-10 codes can be used to screen the population. So basically solitary nodules, and most of other diagnoses will be non-specific lung findings. So with that, lung cancer screening. So this is recommended that any patient who is 50 to 80 years old, currently smoking or had quit smoking in 15 years and has 30-pack year history, should have low-dose CAT scan for cancer screening. This is very impressive. So if you look at number of screening needed to save one life, if you screen 320 patients, you can save one life. Compared to that, you will need 500 colonoscopies and 900 mammograms. So think about in terms of primary care providers, how diligently they are in signing their patients for colonoscopies and mammograms, and how diligent they are screening for lung cancer. Even though lung cancer screening will give you more bangs for the bucks, it's cheap compared to even colonoscopy can be done in less than $100, and it's non-invasive. and it's pretty quick. And you don't need to screen that many people, patients, to save one life. And there's also lots of cost benefit. If you can think, you can save billions of dollars in healthcare costs if they get diagnosed in late stage. So CMS, the Medicare, approved lung cancer screening since 2015. So any patient who is between 55 to 80 years of age, asymptomatic, and who has more than 35-year history of smoking and has not quit, or he has quit in last 15 years. And this will put more than 4 million at-risk population eligible for lung cancer screening. So this Medicare patients, you and me, we all are seeing in our office, recent smokers and 35 years of smoking, they should be screened. And in Florida, we have huge population in this group, and we'll look into those things as well. So the screening is for the patient who are not symptomatic. So if patient comes to us with hemoptysis, they don't need low dose CAT scan. They need a full high resolution CAT scan of the chest. So this is asymptomatic patients who has no history of lung cancer, who quit smoking, and again, less than 15 years ago, and 35 years of smoking. So they might have just smoked for 15 years, but if they smoke 2 packs per day, they will qualify for this thing. This is a statement for U.S. Preventive Service Task Force annual screening for cancer with low-dose CAT scan. So this CAT scan should be performed annual in patients ranging from 55 to 80 years who has 35 years history of smoking. If patient has not quit patient has quit smoking for more than 15 years, then there's no benefit of continuing low-dose CAT scan. Or if patient is not going to get benefited from treating lung cancer, let's say patient has a severe comorbid condition, so limited life expectancy, they should not be screened. So any patient who falls within 15 years of quitting smoking should be screened unless precluded by underlying health conditions. So potential benefits versus harms. The benefits are 20% relative decrease in lung cancer death, as we explained. There's 70% relative reduction in all-cause mortality. So this is again staggering. Very impressive number. It reduces all-cause mortality by 7% in smokers. So if patient has smoked more than 35 years history smoking, between 55 to 80 years of age, this cancer screening will decrease all-cause mortality by 7%. And if CAT scan is negative, then you can reassure and talk about smoking cessation. If they have emphysema, you can show it. Like lots of times, patient comes to us. I always show them their CAT scans, and you'll be impressed. What it does for their smoking cessation method. So if you can explain them, hey, this is how your lung looks like, and once they have visual imagery of destroyed lung, they're more likely to quit smoking. So what are the potential harms? Again, definitely it increases the risk of radiation, but it's just a minuscule increase in radiation. So I don't think it should be a exclusion as far as exclusionary finding as far as cancer screening is concerned. Radiation is not that much higher than you would get radiation from doing chest X-ray. One of the major problems we face is that once you do low-dose cancer screening and tell the patient that they don't have any lung nodules, it gives them some kind of assurance that hey, they are smoking and they don't have cancer, they can continue to smoke. So it should be told them that we don't see it doesn't mean that there's no cancer. If we don't see it because it might be too small. That's why I tell the patient that hey, listen, your CAT scan is negative, doesn't mean that you don't have cancer, but it could be just too small for us to diagnose. So we will repeat it next year and see what it is. Sometimes it can overdiagnose lung cancer. So what it does mean is that if you continue to screen elderly patients, they might have other risk factors which can attribute to their mortality. So you can diagnose lung cancer, but they might end up dying from a heart attack, or they might dying. So you might overdiagnose cancer, which might not have any effect on patient's outcome, or mortality. And sometimes you might have false positive in the sense that you might find small nodules, and then you'll do some more workup, and then turns out to be benign disease. So again, with incidental, with the lung nodule screening, only 2% of patients will have positive diagnosis of cancer. So these are some CAT scans on different stages. This is stage 1 cancer in left lower lobe, somehow in peripheral small lung nodules. This is stage 3, where you can see subcarinal lymph nodes enlargement, and this is again involvement of pleura with stage 3. So this is one of the standard jargon we use to read CAT scan, and again, anytime lung cancer screening CAT scan is performed, the findings will become as a lung reds. So these are the nomenclature we use to diagnose or describe the lung nodules. So again, category 0, it's non-conclusive, and category 1 is shows no lung nodules or benign lung nodules, where you can see some calcification, which is suggestive of benign lung lesion. Stage 2, less than 6 millimeter. Category 3 is between 6 to 8 millimeter. Category 4A is between 8 to 15 millimeter, and category 4B is more than 15 millimeter. So any solid lesions, category 2 is less than 6 millimeter, and 3 is between 6 to 8. So most of the lesion, or most of the lung nodules which falls into category 4 or higher, really needs a workup. That's what it means. Again, there are different, cutoff point for semi-solid nodules or ground glass. Any ground glass lesion more than 20 millimeter should be considered as a category 3. So again, cutoff is 6 millimeter, 8 millimeter, less than 6 is 2, 6 to 8 is 3, and more than 8 millimeter is reds 4. So what needs to be done for this nodule? So again, what it means that any primary category which is less than 3 is probably benign, and short-term follow-up is suggested. So usually the recommendation is that 6 months low-dose CAT scan. Any category 4 or more, so any lesion which is more than 8 millimeter, are very highly suspicious. So further workup needs to be done, needs to be referred to the lung doctors or further testing like a PET scan. Again, it should be noted that PET scan should be done on lesion which is more than 8 millimeter in size, because of otherwise sensitivity is very low. So with that, we're going to talk about what we see in this area. So we'll talk about our catchment area and at-risk population. So we are in Hillsborough County, and we're going to talk about what this is a population-based analysis in surrounding county, and these are the diagnosis codes used to screen this data. So we have more than 1.2 million patients who falls between 58 to 80 years in surrounding county, and our overall smoking prevalence is almost 18 to 20%. So if you look at this 4 million population, out of that is 30% is between 55 to 80 years. That was 1.2 million patients. 20% smokers, so that would be 239,000 patients, and there are more than 90% for former smokers who smoke more than 30 pack years smoking and quit within 15 years. So those will be additional 220,000 patients. So estimated patient will be 460,000 patients. And so after that, patients who smoke more than 30 pack years of cigarettes, there will be 150,000 patients. So these are the 150,000 patients. Our patient needs to be screened with annual low-dose CAT scan. and after that, we will find 12% positive findings. So that will be 18,223 patients will have some abnormal findings which needs to be followed up. This is again from 75-mile radius from our hospital, and it's AdventHealth Tampa. Total cancer incidence is almost 6,000 as far as the lungs are concerned, continue to increase. So projected increase will be 32% increase in 10 years of incidence of lung nodules. So, and briefly, 18,000 patients will have positive findings. With that, it's very important for us to pay attention on screening this patient as we understand that it significantly increases the survivability and it decreases cost. We know that smoking is a major risk factor, so this is a brief slide. Within 20 minutes, their heart rate will drop of quitting, and in 3 months, circulation improves. In 5 years, risk of certain death will go down, and in 10 years, lung cancer risk reduces by half. With that, smoking cessation definitely needs to be reinforced at every opportunity, and this patient needs to be definitely not only screening is important, they need to be diagnosed as soon as possible. As we talk about, if you decrease the lead time between incidental finding and treatment from 5 months to 1 month, you can save more than $3 billion a year in the healthcare cost. So what do we do once this patient gets diagnosed with actionable lung nodule, which is usually anywhere between more than 6 millimeter in size? Depends upon suspicion. PET scan can be ordered. Patient needs to be referred to pulmonologist or radiologist for biopsies, and depends upon the location of the lung nodules. This could be performed. So at AdventHealth Tampa, we offer lots of diagnostic modality as far as that diagnosing lung nodules are concerned. So we have significant advantage in your technology where we can go to very peripheral lung nodules. So this is a navigational bronchoscopy where we really go to a deep part of the lungs, is less invasive, and this is really beneficial to the patient as small lesions can be targeted. So basically, the patient gets a CAT scan done, and we go through the CT-guided pathway to a desired location. It's almost like a robotic bronchoscopy, which can be performed to access the smaller lesions, which sometimes might be difficult any other way. So we can target lesions as small as almost 8 millimeter in size, and really get diagnostic material so patient can be treated aggressively as far as the cancer diagnosis is concerned. So with that, I'll end today's talk. Again, my name is Dr. Neerav Patel, and if anybody has any questions, please do not hesitate to reach out. Thank you very much.